To ration or not to ration? That is the question.
Welcome to the Business of Healthcare, a twice-monthly podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Britt Berrett.
One of the fundamental questions and challenges facing healthcare today is the cost. The cost of healthcare continues to grow at double-digit rates, and for that reason, it has become a serious concern for not only individuals, but businesses and our community as a whole. At what point does this growing cost obligation exceed our ability to handle it? At what point do we say, no mas, we can't continue to incur these exorbitant costs? I recognize internationally as the leader in healthcare education and new technology, the United States continues to spend almost double per capita than any other country in the world. When we look at that number, we peel back some of the elements of it, we recognize that that growth is not in the public sector. It's not Medicare or Medicaid or government subsidized healthcare. It's actually in the private sector. Individuals are making choices, decisions regarding their healthcare and spending an exorbitant amount of money to address healthcare issues. Now, one might ask the question, well, why do we care if it's an individual's right to decide how or when they would make a healthcare purchase? Allow them to do so. Totally agree, totally get that. But those costs continue to grow at such a phenomenal rate. The disparity between the haves and the have-nots is a concern. A recent study with college students, question asked of them was, would you be willing to sacrifice some of your economic well-being to provide health care for others? And the immediate answer of these altruistic millennials has been absolutely, I would be willing to sacrifice. That's an inadequate and insufficient question. The bigger question is, at what point, to which end, or how much would you be willing to sacrifice? I'm going to back up for a second because there's a question that I ask myself on a regular basis. The question is, to ration or not to ration? That is the question. Should we ration, and how should we ration healthcare? As you ponder that question, consider these growing issues. Technology continues to explode, and we're able to do more things than has ever been done in the history of mankind. I would consider healthcare today as the golden age in healthcare. We are able to cure illnesses that in the years gone by were deadly. We're on the cusp of curing cancer. We really are. Consider that cancer is a mutating cell. You have a cell within the lung or the breast or any other portion of the body, and it mutates differently than the cells around it. It's an unhealthy cell, and then it replicates. And as it replicates, it grows and it metastasizes. It goes throughout the entire body, and you find it in all different locations. And then it takes over organs and starts closing them down. So what would happen if you were able to stop that cell from duplicating? What would happen if you were able to cause it to become inert, and all of a sudden those cells that had been mutating, had become cancerous, stopped doing so? Well, you cured cancer. Exciting. But this comes at a price. The research and the studies aren't free. They're not cheap. And then when a discovery is made, there's a desire to recoup the investment, especially in the pharmaceutical space. And so we look back and we whine and we complain that pharmaceutical companies are making too much money. There is a healthy profit margin in many of these slices and segments of the healthcare spending area. But at what point do we say that's too much? Well, if it's someone I don't know, any dollar is too much. If it's my loved one and we can cure their cancer, I think everyone should spend all their resources on that. One might ask, well, how are we rationing healthcare today? It's always gone on. Unbeknownst to many, the rationing occurs behind closed doors within the confines of a clinician's consideration. I'll give you a hypothetical situation. An older gentleman comes in nearing end of life and has some serious healthcare issues that are treatable, but there is no cure. How much should we commit to restore some portion of their ability to function? That's the consideration that the physician and the clinician, they have that with the individual and the family members. It's a very intimate conversation, very personal, and is, in many cases, very sacred. The dilemma that we have is that conversation is being rewritten on a daily basis. And because of the expansion of technologies and our ability to care, it expands the conversation to a greater degree. When an individual is diagnosed with cancer, we would quickly say it's terminal. Today, we're not so sure. There's all sorts of research and possibilities that might allow us to cure that or treat that or prolong one's life. So we have got to move that dialogue regarding rationing from behind the screen to the community. So how much are we willing to ration? How much are we willing to back off and say that the services that we're able to provide probably would be less efficient, less effective, and that the disease process will run its course? I struggle with that myself because I've had loved ones who have gone through that similar process. One embraced hospice care, the other deteriorated, but we continue to invest tens of thousands, hundreds of thousands of dollars of economic value into prolonging his life, which eventually led to his demise. This is the gray area of the conversation. This is the gray area of the ethics of healthcare. And I know healthcare professionals struggle with this. I would suggest that conversation needs to be pulled out front. And we need to ask ourselves, at what point do we as a community support and sustain specific treatment protocol? Let's play a little game. Let's look at an issue of age. At what point do we commit all time, talent, and energy and resources to attempting to restore one's health? Well, a hip replacement, for example. I think we'd all agree it's a miraculous procedure. We're able to restore mobility. But at what point does that titanium hip, is it less effective? Is that at 85? Is that at 87? Is that at 90? Is that at 92? Is that 95? At what point are we going to say the replacement of that hip is probably not ethically in the best decision for that patient? So ponder that question. Now I can imagine you're saying to yourself, well, yeah, 90's too old. How about 85? The sweet spot's 83. Until you or a loved one are 83 years old, you're very active, very mobile, and now you're being denied that care that could restore your mobility. Another question that we would have as it relates to rationing, the first being a conversation about, can we put determinants based on age? The next one is, how about consequences of lifestyle and lifestyle decisions? The most obvious is, do we give lung transplants to smokers? Individuals that are addicted to nicotine and cigarettes, which we know has a detrimental impact on one's health. Do we support and sustain lung transplants for them? Now, you might say, oh, that's a pretty easy one. That's straightforward. Fair enough. But what other treatments do we deny because of an individual's decisions? They have to live with the consequences of those decisions. One of the fastest growing healthcare issues we have in the United States is obesity, and which leads to all sorts of comorbidities, diabetes, chronic obstructive pulmonary disease. We have heart failure. We have a number of comorbidities, and we ask ourselves, well, what of that do you own? Now, the easy answer, the answer we've been giving, well, we should do everything for everyone. Or I can hear some voices say, well, obesity isn't related necessarily to eating habits. It's related to genetics. Yeah, I get that. But let's be real for a moment. To ration or not to ration? That is the question.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
The second segment of today's conversation, as it relates to the issue of rationing, is who makes that decision? Is that decision made by the individual and the family? Let me give you a little personal experience. I've been a hospital president for almost 20 years and recently joined the faculty of the Jindal School of Management at the University of Texas at Dallas. A delightful organization, proactive, looking to infuse business sense in the healthcare delivery system. And as a hospital president, we would run into the dilemma of an individual that had perhaps made poor decisions in life or their health was deteriorating. Many years ago, it became very important for us to establish do not resuscitate orders for ailing individuals and patients, meaning their desire was stipulated on how much life-saving effort should be put into their care. I've got a do not resuscitate an order that, and it's very specific for my loved ones on how much care I want to be provided, and I want to have the dignity to pass as I've determined. Each person should have that right. But when you get into the nitty gritty, when you get into the here and now, in my hospital experience, those do not resuscitates become very challenging if a loved one enters the conversation and is emphatic that grandma or aunt or uncle must be saved, barring any expense, that every effort, despite the patient's do not resuscitate, the family members, they trump that conversation. It's a dilemma. And I've had that experience personally with a family member where a family member was emphatic that despite failing kidneys and all sorts of other maladies, that he would be put on dialysis, to the rest of the family's dismay. And yet we committed that time, that effort, and it eventually led to his demise, but at what cost? And I guess I should even set aside the economic cost. I'm referring to the emotional cost to the family and the will of the individual. Who is going to make the decision on when and where we ration and with whom? Moving forward, we've got to have this conversation because a large portion of the healthcare cost is subsidized by taxes. Communities pay, and then those funds are redistributed to healthcare providers in the form of Medicaid for poor people or Medicare for seniors. We also have something called Medi-Medi, which is seniors that are poor, that they also are provided coverage. Who determines the level of care? Right now, if you're a healthcare provider and you are caring for someone that has Medicare insurance, you're actually taking a steep discount in the charges that you're charging. Now, as a provider, your response to that is just charge the insured patients more. So that's what we call a cross subsidy. But if the Medicare patient needs a lung transplant and they don't want it, or they have lived a life that really should disqualify them, that would not make a transplant appropriate, who's the one that makes that call? What kind of policies must we institute and establish so that we're respectful to the patient's needs and also the obligation that's borne by the community? Who makes that decision? The third segment of the conversation today, as it relates to rationing, to ration or not to ration, that is the question, is when we start making policy decisions related to healthcare cost, what should be borne by the community as a whole? At what point do we as members of this society invest in the health and wellness of the community? As we left the Second World War, a lot of countries came out of World War II really defining who they are and who they would become. Many elected to include healthcare as a part of the obligation of the government. England, European countries, Asian countries, they all decided when and where they would provide that health insurance. We call that socialized medicine, a one-payer system. And they considered it an obligation. So they agreed that they would tax their citizenry. This is in the late 40s and 50s. By the 60s, the U.S. had said, it is not an obligation of government. We don't feel a responsibility. We are not going to provide healthcare coverage. By the 60s, the political conversations had elevated to such a level that they were able to determine that they would provide healthcare coverage for old people, senior citizens. They call that Medicare. And for poor people, Medicaid. But they wanted to make sure that each community had the ability to monitor that. So for Medicare, they made that a national program. Anyone over 65 received full healthcare coverage. The average life expectancy was 65. This was basically end of life, but if you lived in New York or California or Washington or Florida, anywhere in the United States, you would receive the same type of coverage. For Medicaid, each community was demanding that they could determine how they would take care of poor people. So that became a state-run program. So if you're a senior citizen, you can move to any state in the United States. The Medicare coverage will be similar. If you are Medicaid and poor, you can get different levels of healthcare benefit through Medicaid based on the city in which you live. That solved the immediate problem, but still life expectancy in the 60s was just creeping into the high 60s, but that was about it. And we didn't have much technology. Since the 63, 65 passage of Medicare and Medicaid, technology has exploded. We've moved from less than $1 trillion to, by 2020, over $4 trillion of spending. We estimate it'll be 20% of the gross domestic product. That is a lot of economic activity. And further, the average life expectancy has moved from 65 to 75 to 78. Some segments of the population, that number was well over 80. So new technology, longer lives. Medicare can't afford to continue providing that coverage. So guess what they did? As those numbers grew, Medicare just said, we're paying what we're charged. We're going to have to only pay 90 cents on the dollar. And as years gone by, they said, well, we're only paying 80 cents on the dollar. We're only paying 70 cents on the dollar. Today, some hospitals estimate that they receive from Medicare anywhere from 35 to 42 cents for every dollar they charge. So in some cases, they're not even covering their costs. Who pays for that incremental, that difference, that cost shifting? Well, that's borne by people who have insurance. That's borne by individuals who have Blue Cross, United, Cigna, Aetna, and any of the other managed care companies or their private pay. They pay exorbitant prices to subsidize Medicare patients and Medicaid patients. At what point is that unsustainable? At what point do we say, enough, we can't spend these dollars anymore, and we're not going to spend these dollars? That day is upon us. That day is upon us. In 2010, the passage of the Affordable Health Care Act really shifted our direction, and we were fairly sure that health care was a right. Prior to that, it had been a privilege. If you can afford it, we will pay for it. But when we moved into the 2010 Obama period of leadership, we apparently as a community and in a country decided that healthcare was a right. The most recent political changes have shifted that view, but we haven't found solid landing place on, is healthcare a privilege or is it a right? So this brings to conclusion this conversation, a thought-provoking dialogue about rationing of healthcare. At the Jindal School of Management, we're in the business of healthcare. Our intent is to spur the conversation and use smart business practices and processes to respond to healthcare needs. Today, we've been talking about rationing of healthcare, and we're talking about the dynamics that have led us to the point we are today. We're hopeful that the next generation of healthcare leaders, graduates from the School of Management, will engage and participate in this process and be part of the solution. We welcome your thoughts and your comments. This is Dr. Britt Berrett of the Jindal School of Management, where we are in the business of healthcare. Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode notes, links, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app.